Okay.
I can.
Yes, I can see your screen.
All right, and I'm fixing it up, and we'll make this change here. Very slow because I have a slow computer. And there, you should have it as a full screen.
That's, yeah, perfect.
Yeah. There we go. Okay, we're good to go.
Okay, let me just. I think everything fine. Everyone's hearing fine. First of all, I'd like to thank you for accepting the invitation to talk to us. And I know you have a busy schedule, and it's a pleasure to have you here, and it's an honor also to have you talk with us. So I would like to first introduce you, if that's okay.
Sure.
I'm not sure. If I forgot anything, you just let me know. Dr. Russell Margolis is a professor of psychiatry and neurology in the Department of Psychiatry and Behavioral Sciences of the Johns Hopkins University School of Medicine in Baltimore, Maryland. Dr. Margolis received his undergraduate degree from Princeton University and his MD from the Johns Hopkins University School of Medicine. He did his residency training in psychiatry at the Johns Hopkins Hospital, and he did a fellowship in neurobiology at the NIMH. He joined the Johns Hopkins faculty, where he now serves as the clinical director of the Schizophrenia Center, director of the Schizoaffective Disorder Precision Medicine Center of Excellence, which are here. I don't know if you guys moved to the new wing already or not, but here they're building a great center, a great place for you guys. And he's also the director of the Laboratory of Genetic Neurobiology. He treats patients at the Johns Hopkins Inpatient Schizophrenia Unit and the Johns Hopkins Behavioral Psychosis Intervention Clinic, and he teaches students at all levels. His research interests include pathogenesis of genetic neurodegenerative disorders, including 2 discovered by his group, the phenotypic features that may distinguish different subtypes of schizophrenia, the application of advanced neuroimaging to schizophrenia and schizoaffective disorder, and the application of neurogenetic techniques to characterize the pathogenesis of schizophrenia and schizoaffective disorder. So I think that's I think that's a full introduction, brief introduction of Russell Margolis. I'm sure that he has many other abilities and qualities. One of them is that he's a very humble person, even though he's a very great clinician and also researcher at the same time, which is a good combination to have. And he's very easily accessible. I met him a while ago, not in person yet, but hopefully we can invite him to come to Rio de Janeiro soon, and we can show him around. I'm sure we not have the same facilities as Johns Hopkins, but we have a good natural views, and Rio de Janeiro is a great place to visit. So I'm gonna now pass to Russell for him to start his presentation titled Diagnosis and Treatment of New Onset Schizophrenia, Dilemmas and Solutions.
Thanks, Ricardo. I greatly appreciate that very nice introduction. I think what it really should say is I spend lots of time filling out paperwork and trying to make my computer work and keep our old building from falling down on top of us. Well, I have been in Rio once, and it is a very beautiful place indeed. And I look forward to a return visit at some point. I'm going to be speaking mostly about diagnosis today. This combined topic would be worth hours and hours of conversation, but I want to hit some of the high points of diagnosis and also make sure we have some time for discussion. I'm hoping that I can learn something from those of you listening in on Zoom and with new perspectives, because the take here is really my perspective, and there are in fact many controversies, as I will show you. So, well, we'll talk about these learning objectives later. This is from requirements we have here. I have no disclosures, meaning no financial conflicts of interest. We're going to talk about, in terms of this diagnosis of schizophrenia, particularly recent onset schizophrenia or what may be recent onset schizophrenia, some conceptual issues and some definitions, the clinical assessment, lab assessment, genetic assessment, imaging assessment, and autoimmune assessment, and how I think that goes together at this point in time for a clinician making a diagnosis, and what we can look forward to in the future, so that if I were a resident, it would be the kind of things I'd want to be paying attention to, and some of the expertise I'd want to gather in my training. So let's start off with some of the conceptual issues that underlie all of the challenges that we face in diagnosing schizophrenia. So here's the questions we would want to ask as we think about diagnosis. We want to know which at-risk individuals will eventually develop schizophrenia. We want to know, of those who present to us with a schizophrenia-like syndrome, who really has schizophrenia and who has something else? And the third question is, can we divide our patients into more refined categories that will allow us to personalize and improve treatment? I'm going to focus on number 2 in highlighting here. Each of these other topics is important and would be deserving of its own conversation. So let's start with a comment about the term psychosis, which I'm going to be using. I wish I didn't have to use it, but I will. There's really 4 different definitions that people use when they talk about psychosis. So in the lay use, in society, in the movies, it usually means something like very mentally ill, or sometimes people would just say this person is crazy, in some sense meaning something bad is going on, without defining anything further. Freud and others talked about psychosis meaning as detached from reality versus someone who's neurotic, that has had symptoms but was not disconnected from reality. A more precise definition, and the one that I use when possible, is somebody who's experienced some combination of hallucinations, delusions, and disorganized thought or behavior. The problem is D, that sometimes psychosis is used as a synonym for schizophrenia, and that causes a lot of confusion because the symptoms of psychosis, essentially diagnosis definition C, are not unique to schizophrenia, and it can be seen in bipolar disorder, major depression, and in delirium, and the like. The second term that I want to discuss that I'll use frequently, and again, unfortunately, is first episode psychosis, which is used generally for individuals very early in the course of illness or treatment with some form of psychotic presentation. A better term would be recent onset psychosis, because exactly what first episode means, when it ends, when it returns, if someone's given medicine, they get better, then they stop their medicine and they get sick again. Is that still their first episode? Is it another episode? All this becomes very ambiguous. And the other problem is individuals classified under the term first episode psychosis sometimes are the term is sometimes used to mean recent onset schizophrenia, but sometimes it's also used more broadly to include individuals with mood disorders. And often, and maybe more fairly, it's used when it's not quite clear early in the course whether someone has a schizophrenia or a mood disorder or something else. So let's go back to one of the other basic conceptual issues, and that is that schizophrenia and bipolar disorder, as the two kind of root diagnoses, are constructs. These are not pathologically defined entities. And it goes back to Kraepelin at the turn of the 19th to 20th century with his detailed longitudinal patient histories and examination of hospitalized patients, and his belief that we should classify individuals based on syndromes rather than individual symptoms. And he felt the key to diagnosis was this overall pattern of symptoms and course. And if you look at the literature of the time, you'll see that there's dozens and dozens of different descriptions of individuals with all sorts of terms applied to them. And it was really a chaotic moment in the history of psychiatry. And his goal, and along with others at the time, like Bloiler, was to try and create some sort of system out of this chaos. And so that's where Kraepelin came up with his basic divide of two forms of chronic mental illnesses, both with hallucinations, delusions, and thought disorders, and both which he conceptualized as brain diseases. First is manic depression, which has evolved into bipolar disorder, with its intermittent course and symptom-free episodes, in between episodes, and what he termed dementia praecox, which later evolved into what we call schizophrenia, which he thought generally had a more chronic course with a decline in cognitive function. There's this again, this would be another whole seminar on the history of how these concepts have evolved over time. But the basic point here is that these are constructs. This is not like a myocardial infarction where you can look at a heart either with advanced nuclear medicine strategies or post-mortem and say, there is the lesion. And now we can figure out what caused the lesion, what are the consequences of the lesion, but we know concretely what we have, and we can then use that as a basis for refining subtypes of myocardial infarctions, looking at multiple forms of etiology, looking at the multiple syndromes that can arise from someone with a myocardial infarction. We don't have that yet, though there has been effort for 120 some odd years to try and find this central pathologic feature that would help define these illnesses in a more concrete way, but we don't have it. So the other issue we face is something that's been a constant problem in psychiatry, and that are fad diagnoses, which catch the attention of the field and then often the public, and then become distorted. And some of these are blatantly absurd concepts. Some of them are controversial. Some of them are just simply overused in some circumstances, and some of them are just remain uncertain of what the syndrome actually is. So, for example, I'll take the example of alien abduction. So this reached its high point, I don't know, 25 years or so ago, when this psychiatrist at Harvard began to apparently take his patients literally when they told him that they'd been abducted by aliens and were reintroduced to Earth with some various distortions in their mind. And he began to publish about this. And you'd think it would be metaphoric and all, but it didn't seem to be that way. And so that makes our field just look crazy. You know, it's an embarrassment. We have, at least in the United States, and I think elsewhere, there was effort 20 years ago to say anybody who had some sort of psychiatric problem, or many people with psychiatric problem, must have been traumatized. And even if they don't remember it, even if there's no evidence for it, we're going to find that recovered memory. And it led to all sorts of strange things happening, like therapists convincing their patients that they'd been the subject of satanic ritual abuse when they were in kindergarten, for which there was absolutely no evidence of, but which again led to prosecutions and a distortion in the public until, I don't know, 5 or 10 years of gradual correction. And it was recognized that, yes, there are people who've been traumatized. Most people remember their trauma. Some people, it's more obscure, but you can't assume that anybody who has a psychiatric symptom must have some deeply held memory that we have to explore and dig out. ADHD and childhood onset bipolar disorder aren't in the same class. These are just diagnoses that are difficult and context dependent. In the background shaded is one of my most important mentors, Dr. Paul McHugh, who led the fight in many situations to try and keep psychiatry rational. So we have to worry about this with first episode psychosis and make sure that we're not going overboard. And you can see what's happened in terms of the number of citations in PubMed. It just soared since about the year 2000. And there's lots of reasons for that. There's plenty of evidence that has been generated by very sophisticated studies that is certainly going to last and be helpful in the field. But nonetheless, we want to make sure that everything that is said to be first episode psychosis really is first episode psychosis. And here's the dilemma that we face. On the one hand, there's clear evidence that diagnosing someone early in their course of their illness improves short-term and likely long-term outcomes. Not everybody, it turns out. Some people will need long-term treatment and will remain ill regardless of when one intercepts their illness. But in general, early treatment makes sense. On the other hand, the wrong diagnosis of early psychosis, in this case, mistaking it as schizophrenia when it's not, has all sorts of consequences, including medicine side effects, stigmatization, individuals assuming the sick role, and the lack of treatment for what they really do have. And I'll come back to that in a minute. We have another dilemma, and that's of classification. And this is what I was getting to before in how we're still struggling with these concepts that had its origin 120 years ago. We distinguish among the psychotic disorders based on the clinical phenotype. And here I'm primarily talking about schizophrenia, schizoaffective disorder, and bipolar disorder. But this is only proven partially successful. And we know that both from our difficulties and from the experiences in all branches of medicine, that we need to do ultimately a better job of classification, not relying on but rather on underlying pathology or pathophysiology. So, as an example of this classification scheme, I want to describe very briefly something called the BSNP project, which some of you may be familiar with. It's the Bipolar and Schizophrenia Network for Intermediate Phenotypes is what it stands for. Their goal was to use neurobiologic measures to better classify patients with psychosis. And I should add, there's a number of different projects working towards more or less the same aim. I picked this one out because I think it's persuasive and shows a potential way forward, even if they're not right. So they start off with about 700 probands, individuals with either schizophrenia, schizoaffective disorder, or bipolar disorder with psychosis, their first degree relatives, and some matched controls. They looked at a panel of measures that were objective. They used neuropsychological testing. They used various eye movement tests, which involved the ability to control the impulse to look one way when the direction is the other way. You know, you flash a light, you're told to look away from the signal, and how well people can do that, which is difficult. And various auditory stimulation paradigms using EEG measures and the like. use these measures to reclassify the probands with psychosis. So to take all of the individuals with schizophrenia, schizoaffective disorder, or bipolar disorder with psychosis, put them into one bin together, and then use these measures to reclassify them, come up with a new system of diagnosis, and then use a variety of other measures to try and validate the new diagnostic categories that they created. And what they ended up with was what they called 3 biotypes. One were the individuals who had a profound cognitive control dysfunction, and their sensomotor reactivity, which was measured by various EEG parameters, was decreased. These typically were people who had a chronic deteriorated course and were poor outcome. What you might think of as people with long-term, most like people with long-term schizophrenia with negative symptoms, but not exactly, and not defined that way, but defined by these physiologic measures. Biotype 2 had moderately severe cognitive control dysfunction. This is essentially, closest thing to this would be, say, executive function, and markedly increased sensomotor reactivity, again, measured primarily with EEG measurements. And a third group was nearly normal on both the cognitive control measures and on sensoromotor reactivity. So these are not a linear continuum from mild to severe. They are qualitatively different diagnostic categories. And if you look at this is, I think, a cool diagram because I like all the different colors and all. So individuals in the orange circles are people who started off with the diagnosis of bipolar disorder with psychosis. People with plus were diagnosed with schizoaffective disorder before entering the study, and people in triangles were people with schizophrenia. And this is some sort of scale they invented where people looked more like classic bipolar disorder, more like classic schizophrenia up here. And here's how these different patient populations fell into biotypes 1, 2, and 3. While biotype 1 tended to have more people with schizophrenia, and biotype 3 tended to have somewhat more people with bipolar disorder. In fact, the 3 different diagnoses were scattered across all 3 biotypes, so you end up with a very different diagnostic scheme. That's the main point, that you could reclassify patients with a classic psychotic disorder in a different way than what we are doing now. This has implications. It is possible to improve on our current classification scheme by using probes of brain function. And I should add that with their validation measures, they showed that their biotypes fit better than the original diagnoses, say how on measures of fMRI function, on measures of life function for the individuals. So it is possible to improve what we're doing now. Large sample sizes are important, but also this study is just a start. If you started off with different kinds of markers, biologic markers, you might get different and better classification schemes. So it's not that this is the end of the game, it's really the beginning of the game. And the idea is that improved classification schemes have immense potential, that we might make better predictions about the course of individuals with early psychosis, and we might also improve our research by developing more homogeneous groups of patients who would share common genetic and environmental traits, making it easier to identify what the causative agents are in any one variety of these illnesses. And of course, improving clinical trials, because one might argue that the different biotypes will respond differently to a medicine in a way that the diagnoses as we have them may not. And so you might decrease the noise that's inherent within clinical trials. And the BSNP group is working on that aspect of their results at present. So BSNP, an example of what the future can be. We're not there yet clinically. So returning to the clinical evaluation, which is central to the diagnosis still, because we don't have a schizophrenometer, we don't have a hallucinometer, our diagnosis is still dependent on the standard history, mental status examination, and exclusion of other specific etiologies. So the mental status examination is the usual. I'm not going to go into that, but a few problems that have emerged recently, at least for us, and I suspect in much of the world, we now have electronic medical records that often are designed to force us to say yes or no to a specific symptom. And as we'll talk about, particularly with hallucinations, this doesn't work. People don't have yes or no hallucinations. People have possible hallucinations depending on how one interprets it. One might be uncertain. There are different forms of hallucinations. There are experiences the patient has that are more or less compelling when making a diagnosis. That's very difficult to capture in the electronic medical record when it's structured with pull-down menus. And hallucinations in particular, I find, are the most difficult and the least helpful component in making diagnosis, yet often they're used as the key in deciding whether somebody has a psychotic disorder. So I'll give you a case history, patient that I saw. So this is a 20-year-old woman who's at a prominent university, who's referred by her parents to our clinic for a second opinion about the diagnosis she received with schizophrenia. So we have the luxury of taking what we call the Phipps history. Phipps was the guy who donated the money to establish our department about 100 years ago. And so we take a very detailed history. We have a lot of time available to us, several hours plus record review. We find that there's no psychosis in the family history. This young woman had a normal early development. She's intelligent. She's a good student. She has lots of friends, and she's a successful athlete to the point of nearly being professional in her sport. But she's had lifelong anxiety, things she'd vomit before competitions, need support from her parents, no significant substance abuse. So she has a panic attack while studying for an examination. In the middle of the panic attack, she tells her roommate she's hearing voices. There's no other psychotic symptoms, no other disorganized behavior, no functional decline, just this event in a bad panic attack. She's taken to an emergency room. She's admitted to the hospital for 3-day EEG monitoring for reasons that are a little mysterious to me, and it's negative. She has a couple more panic attacks and again complains that she hears voices during the attacks. So she's referred for outpatient treatment and she's diagnosed as having schizophrenia. She's placed not on one, but on 2 antipsychotics, which does help her anxiety. But she begins to tell everybody she knows that she has schizophrenia. And it becomes her explanation for all of her normal life's ups and downs and various problems. Her parents were smart and sophisticated people, and they didn't think this made any sense. So they asked for a second opinion and came to our clinic. And on our evaluation, it's pretty clear she had an anxiety disorder. She didn't have schizophrenia. So her psychiatrist tells her of our opinion. I had to persuade him a little bit, but he finally agreed. The patient herself becomes very upset that she does not have schizophrenia, which for those of you used to treating people with schizophrenia is not very typical. And I don't have too much of a follow-up, but I'm hoping that her treatment is focused on anxiety symptoms and that she's not on antipsychotics anymore. So this is a problem. And in fact, we did a case series of this of people referred to our early psychosis consult clinic for a second opinion. And so of the people referred, these are all young adults coming in, teenagers to young adults coming in with their parents. 54 of these people were thought to have something in the schizophrenia spectrum, or at least a psychotic disorder. And by the end of the time, end of our evaluation, we found that in fact, That was wrong in half the cases, that a number of them had depression, anxiety disorder, bipolar disorder, and a handful of other things as well. And so the misdiagnosis, in this case, the overdiagnosis of psychosis, is a problem. There's some reasons we've thought about for what we might call pseudo-schizophrenia. That I want to, it's dangerous to introduce a term like this because then it can become a diagnosis itself. We don't want that. This is non-schizophrenia, if you will. So these are the contexts that lead patients to describe symptoms that can be misinterpreted as schizophrenia. One, of course, are disorders that can mimic schizophrenia, excluding readily identifiable dementia, delirium, and encephalitis. And of course, it's mood disorder with psychotic phenomena, which is understandably very difficult to distinguish from schizophrenia, and also autism with individuals having odd behavior, particularly if their communication capacity is somewhat diminished and it's hard to know what they are experiencing. Second, and as the example in the case I gave you, was misinterpretation of phenomena or distressed patients. So very vivid thoughts can be interpreted by patients as voices. Sometimes the term voices is used as a general term for distress, as a way of the patient communicating that that something bad is happening to them internally that they can't define, but they now hear the term voices as a commonly used signal of mental illness in society, and so use it themselves. Sometimes societal fears can be misinterpreted as delusions, like the CIA might be listening into my cell phone. Well, they probably are. Or someone's listening in. Maybe it's just Apple or Google. And then, of course, there's malingered symptoms. And there's some common contributors to these kind of mistaken classification of patients' reports. One is individuals who have intellectual disabilities who may have difficulty expressing themselves, similar to an individual with autism. Other individuals who have very intense emotions, like someone with a panic attack or other anxiety disorders or depression. Someone with a histrionic or related personality disorder that tends to think and act in terms of very dramatic statements. And individuals who have a social network collapse and are struggling to find some way to express their distress. Distinguishing all these things is pretty difficult. The best thing we have is a rigorous mental status examination and a lifetime history from outside informants, but we have to be careful that we don't suggest symptoms to our patients that we're interviewing. On the other hand, if we don't ask about them, then we may not find out about them. And it is, I think, incumbent, required of the examiner to be very careful and to know if you start off with a general statement, anything unusual happening, any unusual experiences, and then you become more and more specific, to know that as you become more specific in your questions, the chance of suggesting an answer to the patient goes up. And so you place less weight on the answer that you get. But that is all dependent on the clinical circumstance and context. So we are dependent on phenomenology at this point, what we learn by history and mental status examination, for distinguishing among the psychotic disorders for which there's no other clear etiology. But we have to be very careful, and we have to know that the goal of the field is to move beyond this, but we haven't succeeded yet. Next issue I want to address in the evaluation of somebody with a new onset of something that might be schizophrenia is cognitive testing. So I think that simple bedside or office testing is essential. The mini mental state examination, or the MOCA, which many of you are familiar with, I'm sure, that take about 5 to 10 minutes, that gives some general sense of, is this person significantly cognitively disturbed? That, of course, those are crude measures, but at least helps guide one. If there's no problem, then at least you can be a little bit more relaxed about such issues as neurologic disorders and the like, though you can be fooled. Full cognitive testing, at least in the US, and I suspect elsewhere, is expensive. Here it costs maybe $2,000, may be covered by insurance in part. It's also limited in availability. There might be long waiting lists. And I find that the referrals for this kind of full cognitive testing are best when I have very simple practical questions like, does this patient need accommodations in school? Is this somebody who learns better in oral or written fashion? Is this somebody who needs extra time with examinations and the like, which schools in the United States at least will act on? The problem is these kinds of cognitive tests are often interpreted as though they were a biological test, but they're not. What's happened, though, is psychologists doing this kind of testing often take more time than psychiatrists doing an evaluation, and they write better notes, and there's a certain certainty in the way these notes are written, and there's data, lots of data usually, to back up their position, and so these notes carry a great deal of weight, sometimes appropriately, but sometimes not, and one has to be careful with this, both if one's the psychologist writing the note and the psychiatrists or other clinicians interpreting the note. So here, the primary differential, I think some of this is obvious, so I want to go beyond that, except to say that our key is to exclude other rare conditions that are not part of these primary most likely disorders. How are we going to do that? So what do we want for our routine lab assessment? If we were all in person, I'd make this interactive and quiz everybody, but I won't do that. That doesn't seem quite fair. The standard stuff that we want are standard measures of blood chemistry, of blood cells, more, I think, to set a baseline because some of our medicines have toxicities rather than the fact that this will likely reveal any kind of disorders. Same thing with lipids, hemoglobin A1C. We're going to give medicines that could cause hyperlipidemia or may cause diabetes or diabetic-like symptoms. We want to do syphilis because syphilis can mimic all sorts of psychiatric disorders, and the test is pretty easy, and there's a treatment. Thyroid disease, though I've never seen thyroid disease mimic schizophrenia. If someone has an example, I'd love to hear it. Toxicology screens, because even if the drugs themselves are not the root cause of the disorder, which is, I think, a topic for a whole nother lecture, knowing that a patient is using substances is going to make a difference in their treatment, and routine urinalysis. So these are going to be important for a variety of different reasons, and this is pretty routine. What about genetics? This is harder and we're less developed. So the one type of test that is developed is for drug metabolism, which I do not routinely obtain, but it occasionally can be of value. If you're wondering about a patient who seems to be abnormally sensitive to side effects or doesn't respond to the typical dose of a disorder, one might look at the various liver metabolic enzymes, which is what this test measures, to see if there are any variations in these liver enzymes that might lead a particular drug to be metabolized too faster than normal or slower than normal, that might explain some of the response a patient has, knowing that there is a disconnect between the levels of a drug, which would be affected by these enzymes, and how those levels actually make a clinical difference. So occasionally a value. The problem is, at least what I see in the US, is that these kind of tests are often overinterpreted. Someone finds that the test says, watch out, don't use medicine X because it's metabolized very slowly by this person. And so clinicians will totally avoid that medicine, when in fact, that's not what the test result really means. It just means to be careful. So what about other genetic testing? One of the most common forms are SNP arrays that look across the genome for evidence of deletions or duplications of roughly the size of a gene or a partial or a fragment of a gene. And these arrays for us are still, I think, a matter of controversy. One reason to do it is for suspected 22q11 deletion, which is also known as velocardiofacial or DeGeorge syndrome, which may account for up to 1% of individuals with schizophrenia. And because there are comorbidities that come with having this deletion and relevance of having the deletion for genetic counseling because it would be hereditary, one would not want to miss this, but should it be done routinely? And there are arguments both ways. At present in the US, the cost for this is about $1,000, and it's covered by insurance sometimes, but not other times. We are still debating about whether we should do routine arrays like this, looking for genetic deletions, largely to look for 22q11, but also other duplications and deletions. The problem is many of them are not well defined, and you end up with a test that detects an abnormality, and you have no way to know if that abnormality is meaningful or not. Another reason to do this kind of genetic testing array is if one suspects autism, and also if your psychotic phenomena seem to run with other evidence of a multi-system disorder like dysmorphologic features or various medical, neurologic, or cognitive evidence. This is a field that's clearly going to change. There are now rare variants that substantially increase the risk of schizophrenia that have been detected, but they're very rare, not routinely screened for clinically. And there's been a long debate about something called the polygenic risk score, which is essentially a summation of all the minor risk variants that can be detected genetically in any individual, and whether that has some clinical value. So far, not. But this is an evolving field, and one that certainly those in training should be paying some attention to, so that when these tests evolve, you will be in a position to interpret them accurately. So imaging and the workup of psychosis. So this is a standard problem. So one thing, there's not much dilemma about a SPECT scan, which may be useful for dementia and maybe certain kinds of encephalitis, but it's not useful for schizophrenia, though some groups highly tout it. This is a guy who's famous in the US. He's a psychiatrist who's he's all over the internet. He's now a very wealthy man. And one of the things he does is sell SPECT scans for people, everybody coming to his clinic, and then gives them a reading and says he can tailor their diagnosis by the reading of the SPECT scan. And if you look at some of these reports from the SPECT scan, it'll say, you may occasionally have troubles making decisions and find some emotionally challenging events in your life. And from that kind of analysis, he comes up with treatment. It's sort of like reading a horoscope. So we have to watch out for essentially scams. It's MRI that's the real issue for us clinically, and what we're going to do about MRI scans. So right now, at least in the US, it would be standard procedure to obtain a regular MRI scan of somebody with suspected recent onset of schizophrenia, a recent onset psychosis, to look for things like tumors or other lesions. But I want to tell you about a study that kind of shook me up when I heard it. So this is from a group in Utrecht who looked at about 650 people with something like new onset of psychosis, and a number of matched controls, same number, around 700, and had the MRIs read by a neurologist blinded to whether they were patients or controls, and classified the findings eventually into relevant versus not relevant. And this is what they found. Patient group, 11%. Control group, a little more than 11%. So that there was no difference in the rate of what were considered clinically relevant neuroradiologic abnormalities. This doesn't mean abnormalities that we won't do anything about. It didn't matter whether individuals were in their first episode or multi-episodes of their psychotic illness, and no evidence that in any of the patients' lesions had any relation to their psychopathology. So they argue that it's not essential to perform MRI brain scans as part of the routine screening for psychotic patients. I'll give you a case history that supports this. This is, again, somebody that we saw. 18-year-old girl, 1-year history of absolutely typical schizophrenia. We were asked to give a second opinion. As part of our evaluation, we say she should get a head MRI. That scan shows a small subarachnoid cyst. The neuroradiologist says what neuroradiologists always say, which is clinical correlation advised. They see a neurologist who said it's not relevant. The first neurosurgeon, not relevant. Second neurosurgeon, not relevant. The third neurosurgeon says, well, let's put a drain in and see maybe something good will happen. And what happens is they put a drain into the cyst and she gets a bacterial encephalitis because the drain gets infected. And so now she has two problems. Unfortunately, the encephalitis is successfully treated. Her schizophrenia improves when she's put on a standard medicine. And this all ended up to be just a false positive leading to iatrogenic harm. But there's counterexamples, and this is the problem. So here's a 9-year-old boy who was referred to Hopkins neurosurgery, who had a variety of problems beginning at a young age, and then developed, by the time he was about 8 or 9, auditory hallucinations, bizarre behavior, helped by low-dose haloperidol, normal exam. They get an MRI, and they find a very small third ventricular tumor with hydrocephalus. And here we have the opposite sort of thing. The neurologists say unrelated. First neurosurgeon says unrelated. The second neurosurgeon says operated. It's successfully extracted, and he becomes almost totally well. This happened to be, I picked this case out in part because it was performed, the surgery was performed by a guy named Ben Carson, who's a prominent pediatric neurosurgeon here, who later was Secretary of Housing and Urban Development in the Trump administration, even though his only qualifications were that he owned a house. It's somebody who should have stuck with his day job. But it was an interesting example. And here's one in an adult. Here's a 41-year-old woman, anxiety, hallucinations, aggressiveness and impulsivity, disorganized speech and behaviors. She's diagnosed with schizophrenia, gets better with antipsychotic and an antidepressant, not all the way better, but generally does okay. And then 2 weeks before admission, headache, weakness, red eye, blurred vision, diplopia, so the development of neurologic symptoms, and then she's found comatose, comes in the hospital and has that, which one does not need to be a radiologist to say, uh-oh, that's not good. So this large enhancing mass that's consistent with a meningioma, So it's removed, her medicines are stopped, and she recovers. So what would have happened if this had been done early in the course? We don't know, because it might have been deemed not relevant to her illness. But it's an example that neuroimaging can prove of value. So we have this dilemma. Should we get these scans knowing that most findings will be false positives, but occasionally there'll be something important, or not? The immediate resolution is clear that if there's any kind of atypical presentation, like older age than expected, something atypical in, say, the cognitive function of the person, neurologic signs or symptoms, then certainly get an MRI. But if it's typical, I cannot give you a clear answer about whether to do it or not. In the near future, I think the resolution is clearly going to be quantitative imaging, where we can get much more information out of MRI, but we're not quite there yet. But here's an example. This is the goal of being able to, in a single subject, predict the diagnosis by using imaging. This is going beyond looking for tumors. The goal is to develop algorithms that will help predict diagnosis, course, and beneficial treatment. Lots of work being done on this. I pick out one particular study because it's, I think, quite sophisticated, where they start off with a few hundred healthy controls and 160 schizophrenia subjects, combine MRI, functional MRI, and genomic data into a complicated model that I can nowhere come near close to understanding. Not just the math, but even the terms are a little confusing to me. Some of you who have an engineering background may get this better than me. They put it all together in a neural network that learns itself, and come up with a strategy that can predict, that can separate the patients with schizophrenia from the healthy controls 92% of the time. Of course, the gold standard is a clinician who does it by 100% of the time, but it's the concept that this is where the field may be going in use of imaging in a helpful sort of way. All right, last topic I want to deal with is autoimmune psychosis, or autoimmune encephalitis, which has gained a lot of attention in recent years. So here's the definition of autoimmune psychosis: is an autoimmune encephalitis where there's prominent psychotic phenomena. And generally, these are the accepted criteria, though there's some debate on the nuances, when to think that an individual with psychosis might have an autoimmune disorder, which is the key distinction to make, when it's probable and what's definitive. And you can see possible as if there's a tumor, like an ovarian tumor, movement disorders, neuroleptic malignant syndrome, excessive cognitive dysfunction, decreased level of consciousness, seizures, or autonomic dysfunction, essentially something beyond the standard presentation of new onset schizophrenia. Possible add CSF findings or other imaging findings, and definitive finding is having anti-neuronal antibodies in the CSF, not the serum, but the CSF. So this is the definition. On the one hand, it is clear that rare cases of autoimmune psychosis exist. This is a case reported in the literature of a 27-year-old physician brought to the emergency psychiatry service this is in Europe somewhere, due to behavioral changes over 7 days. She's admitted to the psychiatric ward, becomes incoherent with echolalia, apathy, delusions, mild confusion, disorientation, inattention, and short-term memory impairment. So this is over days. MRI normal, EEG abnormal, CSF shows the NMDA receptor antibodies, which is the most common form of autoimmune encephalitis. Doesn't have an ovarian teratoma. So she's given a course of immunosuppressants She improves, though not all the way well. After 3 months, she gets worse again, another course of treatment, hospitalized for 4 months, also better, but not all the way well. And at the point of hospital discharges, she gets 6 months of cognitive and functional rehabilitation, improves, and ends up back to work as a physician. So it's a good outcome. But I think the key here, there weren't neurologic signs, but there was a very rapid course, and there was a lot of cognitive problems, and then there's EEG abnormalities, and then the CSF proving the case. So these cases do exist, but they're rare. And I give you a study that was just published last month that I think was of high quality and makes the point. So they start off with 104 patients who have some non-affective psychotic disorder diagnosed a mean of just 3 months ago, some a little bit longer. No evidence of an autoimmune encephalitis clinically. So they're looking for cases where is there evidence of autoimmune psychosis in individuals where there's no other sign, because that's the clinical question that faces us. And they have matched controls, which are pretty similar, though they don't smoke as much. And their outcome measures are 7 different anti-neuronal antibodies that have been associated with autoimmune encephalitis. Primary analysis, any antibody in the CSF, none. Patient or control group. In the serum, there were a couple, 2 more in controls than in patients. And even the serum findings were weak. And so the conclusion here was negative, or that is that in 100 patients, you're unlikely to detect anybody with an autoimmune encephalitis as if the patients start off without evidence of something other than routine psychotic presentation. And in fact, that study is not alone. A number of other studies have basically been negative. One study using 741 patients found 2 who might have had some antibodies in their CSF but were weak. Though that author group said maybe there's some vague evidence that some other antibodies, indirect evidence that there might be some other antibodies that are involved in their cases, but it's not a very compelling case. I think this helps us to be rest assured that that most cases do not have an autoimmune encephalitis, at least as we understand it now. And there's a problem, because if you make the wrong diagnosis of autoimmune encephalitis, overdiagnosis, you have other problems. So here's a referral center that looked at 400 people, autoimmune diagnosis, and they found that 25% of them were incorrectly diagnosed, did not have autoimmune diagnosis. And if you look at what those patients actually had, you find that about half of them had some form of psychiatric disorder, what they call the functional neurologic disorder, which we might call a conversion syndrome or an abnormal illness behavior, or some other psychiatric illness like depression, anxiety, schizophrenia, and the like. And the problem is, and you can see where the misdiagnosis came in. They didn't meet standard diagnostic criteria. Various tests were overinterpreted. Psychiatric phenomena were not sufficiently recognized. But the real issue is that this error is not benign, because 80% of the patients with a wrong diagnosis were given immunotherapy, and at least 20 really quite severe abnormal reactions. So there's 2 sides of this equation that I think leads us to the general idea that there's essentially also did not find evidence of autoimmune encephalitis in patients with first episode psychosis, that there's no role for routine antibody screening in non-selective first episode psychosis, If there are risk factors present, then CSF is necessary. And last night, I asked ChatGPT what to do, and it came to the same conclusion, recommending discussion of potential benefits and risks of CSF antibody studies with patient and family, making a decision based on comprehensive evaluation and a shared decision-making approach. It said exactly the same thing when I asked it about whether to do an MRI. So if ChatGPT says it's true, it must be true. So just to wrap up, as a reminder, we have conceptual issues. Psychosis itself, a problematic term. Our constructs are problematic. They're based on clinical findings rather than rooted in pathologic entities, but there is promise for developing objective tools in the future to create better classification schemes. Our clinical assessment is still critical. We have to avoid checkbox thinking, even if our electronic medical records try and make us think like a checkbox. A neurologic examination is repeatedly emerges as very important. And watch out about voices and reports of voices because it's easy to be fooled. Lab tests should be the standard routine lab tests, some for diagnostic purposes and others to establish baseline for making sure that medicines aren't causing tox or monitoring medicines in the future. And hopefully these kind of labs will improve in the future. Genetics, again, if there are suspicions that this is not a standard case, then a genetic screen is relevant. One can debate whether some genetic screens now should become standard. In the future, I think we're going to be moving more and more towards genetics. Imaging, the same thing, perhaps get an MRI, not a PET, looking for rare tumors, but being very careful about overinterpretation. And in the future, hopefully we'll have quantitative measures that will really be a major assist in diagnosis. And autoimmune antibody workup, be selective. And if there's concern, it's cerebral spinal fluid antibodies, not serum antibodies, that are the gold standard. So I leave you with a bit of optimism. This is a person that I always ask audiences if they know who this guy is. Hardly anybody does. This is one of the world's greatest jazz trumpeters and jazz trumpet composers, Tom Harrell, and it turns out I've seen interview clips, and there's no question that he has schizophrenia. They took off the best clip, was removed off of YouTube. It's too bad. And sometimes he has really bad extrapyramidal symptoms, and sometimes he just sort of he gets up on the stage and he just sort of stands there, and his band has to say, "Tom, time to play," and all of a sudden he plays, and the EPS largely goes away. And it's fantastic. And then when he's not playing, some of the symptoms return, though he's still functional. I guess part of the lesson here is that this guy was a genius. He was playing professionally by the time he was 15. He had a very supportive family. His father was a professor at Stanford. He has a very supportive wife. He's very financially well off. And those things are all helpful. Plus, he takes his medicine and responds to medicines. So if things stack up right, it's still quite possible for people with schizophrenia to lead very successful and meaningful lives. So I'll end with that and see if I'll turn it over to Ricardo about questions and timing.
Thank you, Russell. I was just listening to the Tom Harrell before the presentation with the slides. I've heard of him before when studying people with like famous people with schizophrenia, and he's marvelous jazz player. But yeah, you're right when you say that if a lot of things line up right, people with schizophrenia can have a very meaningful and productive life. But it's hard to know when this is going to happen. It's hard to predict in the beginning where it's gonna go. So I think that's one of the major challenges that we have is to figure out the prognosis of people with
Yeah.
schizophrenia from the beginning, right?
Yes,
Looking back,
that's
it's easy, but
agreed. And some of that will be based on better classification schemes and better predictions of using all these tools to say, this genetic phenotype combined with this brain signature by MRI gives this person such and such a type of schizophrenia or psychotic disorder that will respond best to this sort of medicine, or we should go right to clozapine and not
yes,
and skip other medicines, or we don't need clozapine, or clozapine won't work, or something like that.
exactly.
And that kind of information will be really valuable even now, and then eventually, hopefully, when there's more and better treatments, because once you can classify people better, then you can study them better and come up with better pathophysiologic measures and better treatments, hopefully in the long term. This is a decades-long kind of effort, I'm afraid.
Yes. But now with the advancement of advanced artificial general intelligence, maybe we can speed some, at least neuroimaging studies, gonna be able to have some results faster now than we had before.
Yeah, the analytic.
Know.
I think that's true by people who can develop very sophisticated analytic methods and maybe using standard clinical kind of assessments and couple that with standardly available genetic testing, which is cheaper. And you can imagine,
yes.
Like this group from University of New Mexico, led by Vince Calhoun, who is really one of the groups at forefront of this. But there's lots of efforts to try and do this. And the question is, when we'll get clinically by talking to somebody. We're not quite there yet. It's getting there.
Yeah. So I'm going to open up for questions. If anyone, I think Alvaro has raised his hand.
Yes. Thank you, Professor. It was a very inspiring lecture. And I have an annoying or provocative question.
Right.
When you talk about avoid checkbox thinking, are you talking about DSM?
It could be, though not necessarily. So DSM, we know where DSM's origin was for research purposes way back 30 or so years ago, so that the goal was to be reliable, not necessarily valid. And each iteration is by a group of committees, right? They're doing the best they can, but there's political and financial influences upon them. And you could see, for example, in schizoaffective disorder, there's basically just a tiny shift in one word about how much a percentage of time someone has to have affective symptoms to shift from schizophrenia to schizoaffective. So lots of people switch diagnoses, but they're the same person, So DSM has its own troubles. And in fact, there are a number of individuals who I trust who tell me that the main reason that the American Psychiatric Association came up with DSM-5 was because they make tons of money on publishing the DSM, and now they could, even though there isn't there's odds and ends difference between DSM-4R and DSM-5, but fundamentally it's not radically different. But the APA gets to sell a lot. So DSM is problematic. It's something that started out as a reliability measures for research that has taken on a life of its own. Insurance companies use it. Researchers often have to use it. And so that's a problem. And then the other problem is with the checkbox idea is with phenomenology. If you're asked simple questions, if does the patient have a hallucination? Does the patient have a delusion? Well, the answer is often complicated. And so you got two problems. You got the DSM problem, and you got the the oversimplification of phenomenology problem, and together they can make things worse. So we can do our best to try not to let this drag our clinical or research efforts down. Does that answer, Alvaro, does that answer your question?
Okay, Professor, thank you. I think we have the same vision of DSM in case of oversimplification.
Yes.
Yeah, and here in Brazil, unfortunately, for you to do the board certifications, you have to memorize the DSM-5. They ask you specific, like it's more memorization of diagnostic criteria and specifiers and stuff like that.
Yep. Yeah, we teach our residents that too, knowing that they have to do it to pass the boards and also to be able to communicate, but hopefully recognizing it's not a
limitations.
Bible, right?
Exactly.
This did not come down from God on high, that this is the way people are.
Yeah. Let me see if there's any other questions from the people. There are a lot of nice comments. I thank you. If some great comments. Yeah.
Anybody have any questions about it? Please let me know, because these are opinions, and lots of people might disagree with what I said on a number of measures. There are some. I'll give you an example. There are some individuals. There's a famous psychiatrist, I guess he's world famous, named Fuller Torrey, who is written one of the most popular books and best books for families of people with schizophrenia, who I think argues everyone should get CSF testing. And he's not alone in that. Anybody who as an initial presentation, and you could make a case for that as an example.
Yes, I think the thing, if you do it for everyone, there's a lot of resources that go into it.
Yes, that's a problem.
But also at the same time, if you find out early a cause or something, like the reason the person is having this psychotic episode, you can intervene more precisely at the beginning. Hopefully with time, these types of tests or markers are going to get cheaper and cheaper, and going to be more available to everyone.
Well, you're right. It's expensive. Getting the CSF antibodies are quite expensive. It's a long process, and if one does the test on everybody, it means that the prior probability of someone having a true positive goes down, and so you end up with increasing risk of false positives, which is the other side.
Exactly.
So it's a question of whether, and that's why I think at this point CSF testing in the average patient is probably not indicated, because it is as likely to lead to false positives and the like, and to be an expense and a burden, of course, on both the clinicians and the patients. But it's close. Not one can make the counter argument. Same thing with the routine MRIs, PET MRIs. Is it standard practice in Brazil at this point, if someone comes in with recent onset of what looks like schizophrenia, to get an MRI as part of the evaluation?
Most people I know on the first recent onset psychosis would ask for an imaging
or CT, some sort of imaging,
or MRI. Yeah, not on the public service, like if you go to here have a national unified health system, and if you had a psychotic episode and go to an emergency from the public health system, that would be very hard for you to get any kind of exam available. You can't have it, but I'm sure that they don't ask it for every psychotic episode here. On if you go to reference centers and for universities, then probably would ask for MRIs and stuff like that. I had one of the first patients that I took when I was on call for the first time. I got this patient who was transferred from a tuberculosis unit.
Wow.
He had MDR, multi-resistant tuberculosis.
Yikes.
He had a psychotic episode, probably due to one of the antibiotics. I think cyclosporine. I don't remember which ones he was taking, but probably a side effect of one of the antibiotics. And it was very hard. He was agitated, and of course they called the psychiatrist to handle the patient. And we didn't even have the N95s or the mask to talk with the patient. So they put him isolated in a place, and he was there for days until someone could actually go there and take a history and talk, let alone do an MRI scan. So to see, in this case, it was probably knew the cause, the most probable cause of the psychotic episode. But here we have sometimes it's hard to even get an X-ray for patients with TB, let alone an MRI scan or CT scan. But in theory, most people do MRIs when they get a patient on the first recent onset psychosis.
Do you have electronic medical records that force sort of like yes, no answers?
Yes. I have a checkbox, like hallucinations, and I have like even the mental status examination, when you have they have the options for organized, disorganized, how the hair is, and how the patient looks, and how his thinking is, if there are delusions or no delusions and stuff like that. Which is important because it really simplifies something that's not simple and should be, I think, one of the basis of most psychiatric diagnosis or psychopathology and phenomenology. So if you teach that in the beginning, you would, I think that's the best thing that you can do to the students, for them to learn phenomenology and how to describe and distinguish things like from hearing voices, hallucinations, and stuff like that. So they do. So here in Brazil as well, I see a lot of misdiagnosis of schizophrenia. Patients labeled as having schizophrenia when they have sometimes depression, anxiety, or some other mood disorder. And from what you told me, you probably have the same problem.
Yes, though it's also the other way around. It can go the other way around too, where people with schizophrenia are missed, and that's just it's a problem both ways. I see a question in chat. Is it valid to start prophylactic treatment with omega-3 before the first episode on the at-risk groups, ultra-high risk groups? And I would say one thing: I don't think I have the best evidence. I'm not an expert in that. I suspect that the evidence for that is fairly minimal, that it's a fairly benign treatment. And so I'm not sure that there's a clear answer, but someone else might have a better answer to that than I do. It's a good question, though. The general question of what to do with individuals at high risk is a very good concern. I think generally the answer to antipsychotics is no. You treat what's in front of you at the moment, at this point, because our predictions aren't that good. That may change in the future. And so it really is psychotherapeutic efforts, probably keeping the patient away from marijuana, and providing appropriate support and cognitive behavioral type measures. I think would be the most important thing. But I think that's subject to change. I think that part of the field is still in rapid evolution.
Do you guys, I have a question. Do you guys have family programs for people with schizophrenia over there at Johns Hopkins? I think that's one of the major, one of the main things in the treatment process is teaching the family and educating the family on what to do, what to expect, and stuff like that.
Yeah, we do, though I think we could do much better. There are three ways we do that. One is at our clinics, where a patient sees a therapist and a psychiatrist. The therapist and sometimes a psychiatrist will work with the families directly in addition to the patient. So second, we intermittently run a standardized series of family education and support meetings, but there's with a clear curriculum to work them through the various aspects of the illness that we do in groups, and then it allows the families to be supportive of each other. Some of those groups include the patient as well as the family members. And the third is that there are non-affiliated organizations outside of the university that can be very helpful. There's one called the National Alliance for the Mentally Ill that runs many really good support programs for families. And that's of value to many families, though some, not all. Oh, I see another question about the neuropharmacologic tests. So the tests I was thinking about metabolism are the tests that at least we can obtain pretty readily, that look at genetic variations in a variety of the liver metabolic enzymes, to look at how efficiently a given enzyme is likely to work, and so that you can predict for drugs, you can match up which drugs are metabolized by which enzymes and predict which drugs might be metabolized faster or slower than average. That is from, well, I can't tell exactly who it's from because I can't tell where the name's in. Diane, does that answer the question?
Yeah, I think so. As you said before, I think one of the major problems with this types of tests is how interpretation. When you see like this is a slow metabolizer, or you see a red sign next to the drug, it's not that the person cannot take it. It's just that you might have to adjust the dose or something like that.
Exactly, and that's the challenge.
Yeah, and they don't say anything about how the drug's gonna work.
Correct.
It's gonna work on just how it is metabolized.
Correct, which is guidance, but not definitive in any one direction. Yeah. Good. Well, Ricardo and other members of the Grand Rounds, I thank you very much for the invitation.
Thank you. It was a pleasure to have you. I'm sure everyone enjoyed very much your presentation, and it's an honor for us to have you here and talk to us. Thank you for your time. I know you're very busy and you have a lot of duties over there. Yeah, as I said, mostly work like administrative, but thank you very much for having the time to talk to us. Maybe we can invite you to come here in person sometime.
That would be a pleasure. It's a beautiful place.
Yeah,
I'd be happy to come back. All right, leave it with that. But take care, everybody. Thank you.
All right. Bye-bye.